nosebleeds are really common this time of year, mostly because it's dry. We have the furnace on. It takes all the moisture out of the air. Our nose gets really dry and crusty, and then it cracks, and then it bleeds. For a lot of patients, they're on blood thinners, so then they have pretty serious bleeds, actually. It's pretty scary to have a nosebleed. So I'm going to talk about some basic things of what you would do if your nose started to bleed. First and foremost, you'd want to put pressure on your nose. So you use your finger and your thumb and you just hold your nose. And you hold it for 8 minutes, which is a long time, but it's 8 minutes to cause that to clot off, so it'll stop bleeding, okay? And then if your nose does not stop bleeding after holding it for 8 minutes, you would want to spray some Afrin. Afrin is a nasal decongestant that's over the counter, and it stops the bleed. It actually will cause the vessels to kind of compress to stop it from bleeding. And then you clamp your nose back again and hold it for another 8 minutes. I have all of this written down in pamphlets that are up here for you guys as well. But by holding that pressure on the nose, it stops the bleeding for most patients. So at this point, it's been about 20 minutes. If you're still bleeding after all of that, you want to go to the ER. So you need to go to the ER because when we have nosebleeds, they're actually bleeding from our arteries, which means you can bleed out from a nosebleed. And that's why it gushes the way it does, is because every time your heart beats, it's pushing the blood out of the nose. So that's why it's so dramatic. You'll also see it to start clotting, which is also really scary for patients. And then your blood pressure goes up because you're stressed out, and then more blood comes out. So it's pretty major. So you want to definitely go to the ER if you can't get it to stop. The big thing is preventing the nosebleeds, okay? And ways to prevent them are to keep your nose nice and hydrated. To do that would be to run like a humidifier in your bedroom at night while you're sleeping, especially when you're running your furnace, especially in the winter time. You can also put a pot of water like on your register like our grandparents did when we were kids. That puts moisture back into the air as well. You can also take an emollient. So an emollient is an example like Vaseline, Aquaphor. You can put a little bit of that in your nose, not a chunk, just a tiny bit, and just rub it in there. You can rub it with your fingers. You can rub it with a Q-tip, which is the only thing you use Q-tips for, by the way, is to put emollient in your nose, okay? And that helps to give it some hydration while you're sleeping. Some things that will kind of increase your risk for nosebleeds are some nasal sprays like Flonase, also blood thinners put you at a higher risk for nosebleeds, oxygen, wearing oxygen, or a CPAP machine. So all of these things can cause it to be a higher risk, so you want to take some precautions by keeping you hydrated. So if you wear a CPAP, you want to make sure you're having that humidity, the water in the chamber, okay? And then lastly, we recommend some saline, just simple, easy salt water that you spray in your nose. You can do that throughout the day. It'll help keep your nose nice and hydrated too. Your nose does not want to be dry. You'll notice when you have a dry nose, it just runs like a faucet. So if you give yourself moisture, it'll slow down that drainage that you're getting from the nose. So some medical management that you would do for nosebleeds is you could come and see us, of course, and we can evaluate you and possibly do some silver nitrate cautery, which kind of stops the vessel from bleeding. If you end up in the hospital going to the ER, like we talked about earlier, you typically come and see us a few days afterwards. Sometimes they'll pack your nose with packing. Has anybody ever had a nosebleed before? Yeah. It's quite fun, isn't it? It's the best. It's not fun. It's scary. And getting it packed is no fun. But sometimes that's all we can do to get it to stop. Sometimes it can get severe enough where we take you to the OR and have to cauterize it there. But thankfully, that's far and few between that we have to do that. So that's pretty much the information I have on nosebleeds. Oh, some other things that can also cause nosebleeds too is not taking your blood pressure medication. Our blood pressure medications that we take, when you take it, it starts to rise in your blood, and then it takes care of your blood pressure. But then as it wears off, your blood pressure goes up. So a lot of patients will have nosebleeds in the middle of the night because their medicine's wearing off. So those are some things to consider too, is maybe flipping your blood pressure to at bedtime when you take it to cover cover that time frame. The dry eye drops do not dry your nose out, but the whole concept is the same. Yeah, and your lacrimal glands, your tear ducts, they kind of drain into the nose too. So yeah, that it's hydrating it, which is a good thing, right? Any other questions about nosebleeds before we talk about vertigo? No, everybody's good. Okay, so vertigo. Vertigo is a sensation of movement without actually moving. It can feel like spinning. It can feel like off balance. It can feel like your head's not attached to your body. It can feel like a lot of things. So when a patient comes in to see us with concerns for vertigo or dizziness, we start to ask a lot of questions, like how they're feeling, how long is the symptoms lasting, what makes it happen? Does it happen because you're moving, or you move your head, you move your body? Are you rolling over in your bed? Does it happen? These are all really important information to let us know so that we can help you decide what's wrong and what's happening. I had a really fancy picture on there that we're not going to be able to see because it won't work. So I'm just going to talk through kind of why we get vertigo. So vertigo is specifically related to having a vestibular problem, a problem in our inner ears, okay? There's lots of reasons that you can be dizzy, but specifically for vertigo, that's what I'm going to talk about today, okay? In our inner ears, all the way to the brain, we have our balance centers. Our balance centers are on both sides. So we have two of them, both balance centers that talk to each other, and they talk to the brain to help balance the body, kind of tell the body where you are in relationship to gravity. Is she standing up? Is he laying down? Is he rolling over? What's happening? And in the inner ear, we have these 3 canals that are our balance centers. And one canal kind of sits upright, one kind of sits midway, and the other canal sits flat, sort of. And fluid flows around in these canals, how we move. So as we lean to one side, the fluid flows. If we lean forward, the fluid flows. So that fluid is telling the brain and each other where they are, where you are in relationship to that movement. So it often happens in patients, and we're not really sure why this happens, but crystallization forms in that fluid. And if it breaks free and flows independently of that fluid, it confuses the brain. The brain doesn't know, is it laying down? Are you sitting up? Are you rolling over? It doesn't know what you're doing because those crystals are moving on their own. So often we need to do a procedure where we put your, I guess you call it procedure, put your crystals back into alignment. It's a Hall-Pike procedure, and we do these in the Epley maneuver where we kind of put your crystals back into alignment. That's kind of an easy fix. Most patients that end up in my office, though, weren't easily fixed. So we have to do additional testing and find out what's going on. And in our department, we have an audiologist, a hearing specialist, who does our hearing tests as well as our balance study, which is called a VNG. I don't know if you've read in the paper, but we have a new one that we got installed, which is pretty exciting. The VNG is a test that you sit in a chair, kind of like you're sitting in now, and you wear these goggles, and it monitors your eye movements, because your eye movements are connected directly with your balance centers. So when a patient's having a dizzy spell with vertigo, their eyes kind of shake, and they'll feel like they feel that sensation. And so this machine is able to track that movement and find out where's the problem. Is the problem because one balance center's weaker than the other? Is there a problem with the brain not understanding what's going on? So it helps us to determine where your problem is. There's also at our physical therapy sites, vestibular rehab. This is a type of therapy to help with dizziness. It helps to kind of, what happens when you're dizzy? Has anybody ever been dizzy? Okay. So what happens when you're dizzy, you get nervous. You don't want to feel dizzy, so you stop moving like you normally would move. You'll kind of keep your head still, and you'll move slower because you don't want to get dizzy. And then you stop depending on your own balance centers, and then it gets worse even. So the vestibular rehab folks, what we do with them is we'll do some exercises to help you to trust your balance centers again. And if you have a weakness, strengthen it back up so they're balanced. So I always tell folks that, when you have a bad knee, you walk different with a bad knee, and then you end up kind of hurting the good knee. The same is true with a balance center. If you're trying to balance all the time and then it flips you over, that's when you start having the dizziness. Okay? So that's my general information about dizziness. What questions do you guys have? It is, because kind of your brain's pretty awesome. So gets unbalanced and you feel kind of bad for a bit, and then it starts to slowly kind of get better because the brain kind of accommodated. So then what happens is, again, like with the bad knee, you forget almost to walk the right way again. So then you start to have a symptom again. So I give some home exercises, and I usually tell patients when they start feeling the symptoms again, start the exercises again, because that reminds the brain that, oh, here's how we're supposed to be, instead of, letting it flip over. Okay? So that's vertigo, and that's a safety concern. So you do want to make sure you sit, you wait. So if it becomes where it's progressing and not stopping, you need to come see us, because there might be something we can do to help you feel a bit better. There are some medications out there. It's basically they're motion sickness medicines. What they give you mostly is called meclizine. Meclizine is the same as Dramamine that you get over the counter. It does not cure vertigo. All it does is stop the sensation of motion. So I always tell patients, if you're feeling the dizzy spell that doesn't stop, just by sitting there and it still doesn't stop, then you would want to take some meclizine. Like within a few seconds. Yeah. So that's usually an indication is how long the symptom lasts. If it just lasts for a few seconds to minutes, that's a benign vertigo essentially. If something's lasting all day long and doesn't stop, something else is serious. You need to go to the ER. Something else is going on. So here's the problem with ignoring a symptom, because if it stays, if you're laying there and it's not going away, and you can't get up and it's not going away, there might be something else going on. So we do recommend that you go to the ER, because it's also a sign of stroke. So you don't want to ignore it. But if it just lasts for a few seconds and goes away, that's benign and you don't have to get excited about it. But if it's lasting and persistent, that's really not okay. You should go be evaluated to make sure. Yeah, it should not last all day. Now, as a little caveat to that, not to disclaim what I just said, but to feel dizzy or lightheaded or I'm going to pass out, that's a different sensation than having vertigo, okay? And a lot of things can make us feel that way, even simple things like not drinking enough water, drinking too much caffeine, having low blood sugar, having high blood sugar, having low blood pressures, having high blood pressures. So they can all make you feel like that. So kind of evaluate, have I been eating, have I been drinking, are my blood sugars okay? Those are some things that you can look at right away if you're not feeling well. But if it persists, it's not something to ignore. You want to definitely go to the ER. You can throw up, you can be nauseous, you can have vision changes too, because you just can't focus on a certain spot. Some patients say if I just sit still and don't move, I feel better with vertigo. And that's kind of a key, like what you said, if it just doesn't stop. If you're still, or if you're laying down and you're spinning while you're laying down, maybe turn to one side and see if it goes away, or the other side to go away, because it might just need, that crystal needs to get settled, essentially. But it shouldn't last all day. So balance is not simple. It's complicated, but I've tried to make it as simple as I can. But it's not just your balance centers in your brain. It's also your vision. It's also your musculature to hold the machine up, to walk it down the hallway. So all of that kind of adds in. And if we have poor vision, that affects your balance, because you can't see the horizon, so it confuses the balance centers. They need to be able to see. That's why people get seasick, because the horizon keeps moving and they get sick and vomit. So anybody can get vertigo, any age range, okay? But as we mature in age, it's more frequent, it's more common. And then we worry about falls and breaking bones, because that gets even worse. So holding on to something is very important. The way to explain to someone who's never had vertigo before is being on a merry-go-round that spins and spins and spins and spins, and then as it stops and you still feel the motion, that's vertigo. So that's an example of what it feels like if you've never felt it before. Keep active. Practice your balance. A lot of it has to do with balance. There's a lot of stuff that you can look at online. There's balance activities to not be as sedentary if at all possible. More movement is better. More muscle is better. You can build muscle. It's not so much about, running or cardiovascular. It's more about building those support muscles to move this machine. But nothing really prevents vertigo. So the only way we can ever actually see the crystals or how we ever found them was post-mortem after somebody has passed away. So this is, they call it different things. Actually, they'll talk about it being like a pressure change. So a hydrops, like you're missing some of that fluid in there, and that's why you have the imbalance. They're all speculative, though. They really don't know, but they do know what helps it, and the exercises are what help it. And the funny thing is the exercises are moving your eyes, which is a weird thing, but your eyes are directly connected to them. So the exercises are you moving your eyes back and forth and doing all this weird, it's weird, but it actually helps patients. Yeah. So it's not, you're not going to go to physical therapy and walk on a treadmill. That's not vestibular rehab. You're going to be moving your eyes around. The semicircular canals are at your brain. So not even then. We don't look for them. We don't go looking for them. Nah. No, they were found, yes, they were found incidentally as we were learning medicine, you know what I mean, through time. But no. When we look in your look in your ears, all we really can see is the ear canal. We can see the eardrum, and we can see through the eardrum and see the bones. That's about it. And then if there's any fluid or anything, we could see that too. But you cannot see to the inner ear because that's at the brain. So we can't see the brain. Like when I clean ears, people are always like, "You're not going to take out my brains." No, can't get to your brains. So we're okay there. So people's hearing decline at different rates. There are profound hearing losses in patients. There's also people that will get a total loss in one side and not the other. So when there's a total loss, there's no point of a hearing aid. But if that's what I would call a dead ear. So age does not cause hearing loss. It does not. It's actually genetics. It runs in families. It runs in families, so you can look at your siblings and your parents, and that will predict where you're going to end up because it's all genetics. Also, we lose hearing due to exposure, like a sound, noise, that kind of stuff you can lose hearing. You can lose hearing due to viruses. Viruses can latch onto the nerve and take your hearing. It's usually one-sided, but there are lots of reasons for hearing loss, but it's not typically age. Like I have 90-year-olds that have good hearing that come to see me, but yeah, it's not aging. A lot of times it's exposure through your jobs, especially when we were younger. They didn't know to protect your hearing, so you kind of had that damage a long time ago. So and it catches up later, obviously. Usually they catch up to each other is usually what happens, but it can happen where you only need one. But it does typically tend to equal out. Patients that can't hear will regress and retreat and not participate. And then you'll talk to them and they'll just nod and they don't even ask you what you said because they don't want to ask you again because you've been asked so many times. Or they'll be like, their family gets upset, like, why aren't you listening? And it's like, I really just can't hear you. So what I tell patients too is even if you're wearing hearing aids, you want to make sure you're giving them eye contact when you're talking because they're reading your lips. They really are. And you want to not talk and walk away from them because they're not going to hear it. And then to get their attention because they're not ignoring you. I mean, maybe, but probably not. They're probably not ignoring you. So it does. It's a little frustrating, and you do feel not connected to what's going on around you, especially if you're out in a group setting. You're missing a lot of what people are saying. And it's really important to let your family, your friends, your loved ones know, I'm really just not hearing you. And so that you can have that conversation. Yeah, and it's not going to say that in a nice way. And it's not going to be just one time you say it. You're going to have to continually reinforce it. So, but I'm a big component of hearing aids for that reason, just because I've seen it personally, what happens when you can't hear. And you get depressed and you get less involved and it's sad. So I really recommend them if you can afford them. Yes. I tell my folks about once a year or if you notice a change. So we have an audiologist in our office that comes and she sells hearing aids. And the way she does hers is, and she's independent, but the way she does hers is she doesn't set them to the highest possible setting right away. She starts at low and then they slowly increase so that you're not like, rah, you went from not hearing to hearing all this stuff because it gives you a headache actually. So whenever there's a change or you notice you're turning your TV up even louder than you normally did, that's when you would want to get them checked out. And that should be part of your service, is that you're going to get a repeat hearing test and they adjust your aids. Now, there are limits to adjusting them. I want to put that, it's not, I've had patients where we've got to the point where we can't adjust anymore. They just aren't going to be able to hear. We have to think of another alternative. Maybe captions on their TV. When the phone call comes in, captions come across. So there are other options. It's just, it's sad, but it's part of it, unfortunately.
So do you do the actual testing?
We do.
And then refer to
So we do the testing in our office, and then it in the hospital, in the specialty clinic. It's connected to the hospital. They call it the medical office building. It's the middle door if you're looking at the whole hospital. I think it's door A. So that's where we're at now. We've always been there. We're on floor 3, but we do the testing there, and then I do the medical evaluation, and then we determine whether you need hearing aids or not, what kind of hearing aids you should probably get. And then we, based on your insurance and what your insurance will cover, you go to wherever they say, if you're lucky enough to have coverage. If you're not lucky enough to have coverage, I always recommend you to our audiologist because her prices are more manageable because she doesn't have a store or anything like that. So I always say, if you think you're going to need hearing aids, call your insurance and find out, do I have coverage? Do I have coverage? And if I do, how much do I have and where do I go? Because it's very specific to the insurance companies. We don't get to pick it. And if you don't have coverage, shop around, ask lots of questions, comparison shop, because it's like buying a car. So that's the consideration. Just like when you buy a vehicle, you go buy a car, you're going to talk to them about their maintenance plans, what are you going to offer me? So that's going to be part of when you buy hearing aids. You're buying hearing aids, you're buying a service as well. Where are you located? Do you guys winter in Florida? Do you have a site in Florida that I can go to? Mm-hmm. So I will tell you, hearing aids are a little bit to get used to be honest with you, because they're a little bit to get used to because they're digital. They're digital hearing. They're not your normal hearing. So people expect when they put the hearing aid on that they're going to hear like they did when they were young. But that's not going to happen. Hearing aids aid the hearing you currently have. So it's only as good as the hearing you have. So as your hearing declines, the hearing aid's going to do a lot less because, say, normal hearing's here and your hearing is here. As it declines, it can only bring it up so much. So it's never going to be perfect.
So say like you have
No, because there's only a couple brands out there. They're all the same ones. And so based on your loss determines what type you need and if it should go over the ear, if it should go in the ear. So not really, no. Mm-mm. So what they're buying on Amazon is called an amplifier. It's not a hearing aid. And what an amplifier does is like when you turn up your TV. So when you buy them from Amazon, you're buying an amplifier. When you're buying a hearing aid, it's programmed to you. Whatever your losses are, they program the aid to only amplify where you need the loss. Cochlear implants are amazing. They really are. They're for people that are almost totally deaf. They put them in newborns that are deaf upon birth. They put them in people that have complete loss of hearing. It is a brain surgery, however, and so it's not a light undergoing, but if it is very extensive. They implant transmitters into the brain itself.